So I'm Troy Erickson, and we've been living here in Grand Rapids now. I think it's going on 4 years, but we had a cabin up here for, it's going to be, I think, 9, almost 10 years, but now we have our home up here as well. Grew up in southern Minnesota in a real small town, and then went to medical school and then off to Detroit, Michigan to do my residency. So it's always fun to go from small towns to big towns and then back to the small town again. But today we're going to talk about, we're going to cover a lot about the shoulder. One of the biggest things that I try to stress about shoulders is, any time I do talks, it's usually always anatomy first. I shouldn't say usually. It is always anatomy first. So if people, no matter who it is, if you can understand a little bit about the anatomy, you can understand why it hurts. You can understand why it fails, because, like, you know, think about a mechanic. That's all I really am, is a mechanic. I don't get the luxury of having something just fall apart on the side of the road, you know, because then I'm in big trouble on that. But we're going to go through it. We'll talk about some of the diagnostics. We'll talk about how we go through part of the physical exam. Most importantly, how you guys can protect your shoulders, because the shoulder is a very, very poorly designed joint, and it has to be, because no other joint in your body can spin 360 degrees. The hip is probably the best designed joint in your body, and they last. They really last. And if you replace a hip, that's the orthopedic success. You know, other things we're not as good as we are at taking care of hip stuff. So, and with no further ado, here we go. So I talked about our objectives here, and it's important, you know, that I cover all those. So as I said, the shoulder is a very complex joint. It's made up of bones, tendons, ligaments, and muscles. And it needs to be, like I said, very complex. It's like the Golden Gate Bridge, and that's actually, in one of our textbooks, it actually shows us that. It's suspensory. If I mess up part of that bridge or one of the stays coming down, the shoulder or that bridge would wobble, and that's what happens to our shoulder. So then I start overusing it. Our car tires. You know, if your cars are out of alignment, what happens? You're going to have to get new car tires, you know, because you're wearing out one side. And it's interesting how it works. So when we talk about the anatomy, I'll go through the bony. Just very quick, you see the front. So the shoulder is made up of the humerus. It's made up of the shoulder blade, which is the scapula, and the clavicle. But none of those things are attached to each other. You have ligaments or tendons that kind of stick them together. So it's just kind of hanging out there. But, you know, think about it. You can swing this arm all the way around. Now, this shoulder, I can really talk about shoulders because I had shoulder surgery 8 weeks ago. So you won't see me lifting this one a whole lot yet, but I'm getting better with it. So I understand the pain of this surgery. So from the back, you'll see like how the spine that you feel on the back when you lay on that, and then it comes up to the acromion. But there's muscles attached to everything here, and then they go out and go around the humeral head that kind of suck it in. So if we can keep those muscles stronger, it keeps that shoulder held into its position. Here, you get to start seeing some of the tendons, and you start seeing some of the ligaments. So a tendon, and I have my daughter here, so I could actually question her about this, but I won't. But a tendon is a muscle to a bone attachment. And so everyone says, oh, I got a rotator cuff tear. Well, what's that really mean? Well, the rotator cuff has 4 muscle tendon junctions. It's not just a rotator cuff. It's everything and how it works together. The ligaments are connections between a bone and a bone. So hockey players, if every good hockey player, and I say that, all have AC separations because they get hit, knocked against it. Wrestlers, football players do too. Here you see all the muscles over the top, and the muscles are what kind of, like I said, pull this in and hold it in its position. With the muscles and everything too, you see the vein, you see the arteries coming out. They come through an interval, and that's very important to us as surgeons because that's how we do our surgery. That's how we get into different areas. We work through intervals. The deltoid, as we're going to talk later here, is the most important muscle in that shoulder. If you guys lose your deltoids, you almost eliminate every operative procedure you can have. So it's important to keep a deltoid. You can live, and everyone listen to this one, you can live without your rotator cuff. It's painful, but you cannot live without a deltoid. You have an arm that just hangs, and it does nothing. And so looking at the muscles from behind, you can see we've dissected from one side out, looking from the patient's left, looking over at the right. And so you're working your way down through all those layers. And then here, so each slide, it's like I'm kind of taking away one, how would you say, like peeling the onion. So taking off each layer. And now you start seeing all the nerves. And look at how these nerves come out underneath of them. And so in your armpit, you know, patients come to see me and they're complaining about my arm feels numb and stuff like that. Well, if you're having shoulder troubles and it's hanging down, you're putting pressure on the nerves. And here comes a bunch of the numbness. So sometimes someone showing up to our office with ulnar nerve or carpal tunnel symptoms really has a shoulder problem, you know, and then they just snowball on top of each other. So you got to put it all together. The most important nerve up there is actually the axillary nerve that sweeps out to the deltoid, because that's what makes the deltoid work. And if the deltoid isn't working, once again, you have no options. And we go back to the day when they used to do breast biopsies, breast surgery, and they would do axillary node dissection. A lot of times they hit that nerve, and these patients, we'd see them, they had an arm that was very edematous, very swollen, and it didn't work. It had a blood flow, but there was no function in it at all. You had this big, in essence, a dead arm, you know, and it's something else, but you don't see that as much. So, once again, the rotator cuff. Everyone says, I have a rotator cuff tear. Well, what muscles are they? Supraspinatus, and you remember them as sits, S-I-T-S, just like we're all sitting down here, sits. Supraspinatus, infraspinatus, subscapularis, teres minor. And they sweep over the top and down. That's the way we remember them. And here's a patient laying down. You can see the supraspinatus sweeps underneath the bone. It comes underneath the acromion. It comes out and attaches. Subscap to the front, infraspinatus, and then the teres minor is down low. You almost never, ever see a teres minor torn. In my career, it's 17 plus years now, I've never seen one of those torn. I've seen all the other three torn though. And that's when we get into massive rotator cuff tears. So, small, easy view, supraspinatus sits on the top. It's one that runs underneath the bone, the acromion, and it slides back and forth. So every time we raise that arm, we're going up and down, we're raising up and down. I am sliding against the bone spur. And guess what happens as we all get older? Our bone spurs get bigger. As they get bigger, I rub more, I get a hole in it. So everyone over the age of 50 has a partial rotator cuff tear because we all reach. If I kept my arm down here and did nothing above it, I wouldn't have a tear, but that doesn't happen. Infraspinatus is just a little bit lower. It's the second most commonly torn. Teres minor, like I said, hardly ever torn. And the subscapularis is our front one, and it's actually the strongest of all of the rotator cuff muscles. It's rare to see that one injured unless someone has seizures, because it's an electrical event, or with electrocutions, someone that's working for Minnesota Power, let's say, and they get jolted. That muscle contracts, it pulls the shoulder right out, because it's that strong. So here, now we're looking at some of the tendons, we see some of the ligaments. Once again, you see how intricate this is, and that's why I get so excited, because it's like you're always trying to figure out what part's off, what's wrong. And then trying to put it back together sometimes, and sometimes you can't put it back together. And I will be showing pictures of when some people have waited too long. So deltoid, once again, I try to drive this one home. Deltoid, deltoid, deltoid. That's what we care about. You know, without it, you're in trouble. You will not move that arm at all. You ever watch, you know, as we get into the basketball season and stuff, or the March Madness, you look at the NBA players, look at how huge their deltoids are from shooting the basketball all the time. You know, they just build up, but then they really run into troubles later in life with their arthritis. So there's that axillary nerve, and it swings out and it comes around. And this is very variable. You know, we have all kinds of these interesting studies, and I could bore you to death with them, but it can vary from the top up here. It can be within a couple centimeters. It can be much farther down. So where do most of us get our shots? Exactly. And that's one thing that I give a talk like this to family practitioners. I give it to nurses and everything. If you're putting a needle in someone's shoulder, and especially if someone's very, very thin, you better use a very small needle, meaning not very long. And if that patient says it's burning, you stop immediately and get that needle out. Because I've seen 3 patients who got shots who lost their axillary nerve and did not have deltoid function. And one was at 9 months, she was still out, still nothing yet, So I say, and you say, well, I'll get one in the buttocks. Well, you can hit stuff there too, and so it's hard to go to Walmart and get a shot to drop in your pants, but make Walmart interesting.
Yeah.
So, and here's like kind of our dissection, and anytime I do surgery, I always put a big mark across it. I put a ruler, I put a mark to remind everyone, watch out for that area. So now we get into what are some of the common causes of pain. Doc, it hurts. Okay, let's talk about what hurts. How does it hurt? What triggers it? So some of these things, and we're going to go through each one of them. Impingement syndrome. Many of you guys heard that? Show of hands. You don't have to raise very high. Good. Acromioclavicular arthritis, which is arthritis at the clavicle. And if, as we get to summertime now, you'll start seeing all these big bumps that people have. That's AC arthritis. And both of them lead to rotator cuff tendonitis, and eventually they lead to tears. But a lot of times everyone says, I have bursitis. Well, bursitis is inflammation of the bursal tissue caused by the bone spurs. And that's how it would look. So the blue on the top there underneath the acromion shows the arm down at my side. As my arm comes up, I impinge on the bone spur and I pinch that bursal sac because there's a small area. And now I get inflammation. That inflammation is what hurts because that big sac comes way down and everyone comes in, oh, I got a pain here. So, well, you got a rotator cuff. No, I got a pain here. Well, that comes down and what's it irritate? That axillary nerve. I.e., that's why we see this pain down low. So kind of another picture of it, Now if you fell and you landed hard, you drive that bone up against the other bone real quick. You can get quick tears and you can get the bursitis, you can get this really fast. And that's a different situation versus the wear and tear of life. It's like having a car accident versus my tires are slowly wearing out. One's a sudden thing, one's slow and methodical. So another picture shows kind of the bursal sac and everything around it. And as a surgeon, we talk about the acromion, which is the bone that comes across the top, which is part of your shoulder blade. We're all born with a certain type. There's type 1s, types 2, and type 3. And what it is, the type 3, of course, as you move up numbers, bigger hook. Well, every type 1 becomes a type 2 in our lifetime. Type 2s become type 3s, and some of us get the bad luck of having a type 3 right away. And they're the ones that 30 years old and they got a rotator cuff tear already. You'll see these more often with certain jobs. You'll see them earlier in life. If you're a carpenter, you're sheetrocking, you're doing overhead activities, electricians, they keep working over the top. It pulls some bone off that corner. The ligament pulls on it, and what happens? Your body thinks you broke something, and it makes more bone. So the bone spurs get larger. And that's why they get bigger and bigger hooks. The bigger the hook, the quicker you put a hole through something. So these are what x-ray views look like. You got a type 1, type 2, and type 3. And you see that all the way over to the left. Look at that big kind of point down. It doesn't take much to drive that through your tendon. You can see the differences in space. Now this is an AC arthritis, acromioclavicular, so the joint is the AC joint, and see how that spur comes down at it. Same thing, it takes up room. It's sliding underneath of it, eats away at it. So as I said, they just dig in it and they tear away at it. Trauma, very quick. You press up, you fall down, and boy, if you fall and you can't move your arm, you can skip see, and I hate to say this, even the family doctor, go see the orthopedic surgeon because we move fast. And if you have a tear and we can get to a tear within 6 weeks, an acute tear, they heal really well. If you start waiting too long, it gets to a point where sometimes we can't fix it, because the muscles atrophy and go away. So acromial spur again. This is an MR arthrogram showing a really big spur. I put the arrow on that. And there's dye all over, which means that rotator cuff has been torn and the dye is leaking everywhere. And that's what a rotator cuff tear would look like looking through my arthroscope. So I got the scope in the shoulder and I'm up by where the bone spur is and I'm looking right down on it and you see the big hole on it. You're looking right down on the top of the humeral head. That's what's in the side of that's the center of that hole. And then here it talks about spurs and then how we get the partial tearing into the rotator cuff themselves. And you see you can have them from underneath and you see them from on top, different ways you get your tears. So same thing, we're looking at it, and this is an MR arthrogram, and we're going to talk more about it in a little bit. Now, kind of shifting gears, so I've been talking about over the top. Now you can have stuff that's down deep in the ball and socket, because the shoulder is a ball, a socket, think of tendons on the top, acromial spurs. But where the ball and socket sit, there's a labrum that circles around it, which acts like a suction cup. So if you take a, suction cup and you stick it on a table, it's almost impossible to pull it off, right? Well, what happens if I crack it just a little bit? It comes off right away. The labrum, think of it as that suction cup. It helps hold the humeral head in its position with all the muscles and tendons around it, but it helps keep the suction cup effect. So if I have a tear in my labrum, I shimmy out of it. If I shimmy out of it, I hit against the bone spurs more, but it's because I'm walking all over that joint. I'm, once again, out of alignment. So the circle part here, so we're looking now, I'm looking at, you're all looking at the shoulder this way, get the humeral head out of the way. You have the rotator cuff muscles that surround it. They're cuffing it. That's how it gets its name. The humeral head would sit here. This is the labrum that goes all the way around, and it deepens the socket to make it a little bit bigger. That's why I said before, the hip is so great. The hip's a big bony socket, and it holds it great. The shoulder is very flat, wiggly, you know, and that's why shoulders have problems. And then your long head of the biceps comes in and attaches deep inside. You have a long head and a short head. So another kind of drawing of it, same thing. You see the labrum labeled there. You have the biceps coming in, and then it centers it, but it's a suction cup. Arthroscopically, this is what it would look like. So I have a arthroscope in the back of the shoulder. I'm looking at the glenoid, which is this yellowish color here. The labrum goes around, and this is my probe. And then on the other side, you can see how it's torn. So it's letting the fluid down and around. And so you've lost your suction cup. And I talked about the long head of the biceps already too. And the long head of the biceps is attached to it. In my, like I said, it's been about 17 years, I've watched going from doing everything open for shoulder surgery to almost everything done arthroscopically now. I've watched where we've worked so hard in fixing so many labrums, now we're almost moving to fixing very few labrums, and we're dealing more with the long head of the biceps, because the biceps is actually one of the more problematic things. So I had a labral tear myself, so how do they address it? They don't fix the labrum, they actually cut my biceps off, and then they anchor it in the bone outside. So I still have that function, but otherwise I kept trying to peel off my labrum every time I'd fire my muscle, and then the biceps is jumping around. So we're finding now as these years are going on, we did a pretty poor job of addressing the true pathology, what we should have been looking at before. And so you can see how the biceps long head comes up, goes through a little groove, and anchors. The short head comes up and attaches out here. Now I don't know if anybody in here, men and women can have it. Usually the guys, anyone have what we call a Popeye muscle, where the muscle sits, there we go. And so what happened for them, we say, and it's called Popeye, they ruptured the long head of the biceps. Depending on our age, you just let it go free. A lot of times I cut it and just let it go free. The muscle shortens, and it stands out really nice. It makes you look really good on the beach. But you have a short head attachment, so it still works, but it just shifts down. So biceps meaning 2 heads, like bicycle. Triceps, 3 heads, so the triceps, and that's how, we're in orthopedics. We try to keep it real simple on that. But it depends on your age and when you should have them fixed or released or what needs to be done with them. And so you can see here's where biceps, it's pulling. We talk about the slap tears. You hear about a lot of the sports people having it. Anyway, if anyone knows Drew Brees, he had a big shoulder dislocation. He went on and he tore his whole labrum off all the way around. Ended up doing rehab and lived with his surgeon and with the therapist forever. And I remember because we lost to him in the Super Bowl, and his surgeon, Dr. Andrews, was showing all his MRIs, what they did for surgery and everything like that, and he recovered. But he tore his labrum completely off to make it, and then he made it back. And it's like an injury that none of us would get back, and it was amazing. And same thing, still showing some slap tears, labral tears. Now, hopefully not anyone gets too queasy, but now we move into the other part inside the shoulder that hurts. This is just pure arthritis, ball and socket arthritis. You can get this from many different things. We can get it from, it's called avascular necrosis, meaning I lost my blood supply to my humeral head. And so it mushrooms, it just kind of collapses on it. It could have been a trauma. Some of it can be related to steroid use. It can be all kinds of different things. Working in Detroit, we saw lots and lots of young people with this because they had sickle cell anemia. And it knocks out the blood supply. They lose the humeral heads and they lose the femoral heads, so hip and shoulder replacements. You put up x-rays and you see 2 shoulder, 2 hip replacements in very young people. But that's what the x-rays show, that's just smashed up. There's no joint space. And over on the right side, that's what it looks like when you have it exposed to replace it. Lots of arthritis. That's all that kind of big knots. And that's how our knees would look. That's like how our hips look. Arthritis is arthritis that way. So how do we prevent some of this stuff? And that's the biggest part. You know, that's why hopefully most of you guys are here, is we want to prevent running into troubles. So life is motion, motion is life. So it's a saying my attending who's been doing orthopedics for 40 plus years taught me, and you carry it through. If you're not moving, nothing good's coming out of it. And the shoulder is even the most important. I've seen people with hips that barely budge and they get along okay. A shoulder that doesn't move, you basically have lost your options for caring for it. From a surgical standpoint, because you have to have motion. So even if someone doesn't have a deltoid and I can move their arm, or you have a massive rotator cuff tear and I can move their arm, they have options. But if I have something that doesn't budge, we're in trouble. So even when some stuff hurts, we want to keep motion going in certain planes, and I'll talk some more about, but you don't want to put strength into it. You want to use it in safe manner. And so when it comes to it, and there's handouts, you know, I get handouts that talk about this. You know, it's easier to kind of look at them. They come from the American Academy of Orthopedic Surgery, and if you ever go onto the internet and you pull up, there was more stuff there than I could ever imagine, and they really work through it. You know, and from different ages to, be it hips, you name it, every joint in the body, they had something written about it. But we want to stay limber. Some of the patients who I've seen that have done the best in their lifetime are those who have done yoga and Pilates. And why? They're just more elastic. So when they fall down, they kind of go with it. If I fall down, I am so rigid, I break apart, you know, and that's a big part of it. And then we always want to make sure we are stretching. So you stretch a little bit. So let's say you're going to come in and you're going to warm up. You know what? It's better to do the motion on one of those pedal bike things. Get the arms going. Get them warmed up. Now go do some longer stretches. Get them going. Do your workout for your upper body. Then go stretch again, because the most important stretch is when you're done working out, because everything's warmed up. So the pool, you know, here we are so lucky we got the pool. It's relatively warm. You get in the water, the resistance to the water, just stuff to kind of get stuff limbered up, but it's also a nice way to finish that workout as well. So proper mechanics, you know, the therapist will pick on you about this, but you know, really as you go into it, like I say, I did the sheets because it lays it out better than I ever could lay it out, and it's more concise, and more importantly, you can carry it around with you. So that's important. So like I said, use the pool, whirlpool, those are the things that loosen up all joints the best. If you have soreness, you know, kind of work into it a little bit. But weakness is something we don't want to see. All of a sudden it's like, boy, I have no strength to it. Something else happened. If the soreness is continuing, you know, there's the workout soreness, but if you're getting soreness that just isn't going away, you know, really stop what you're doing. Keep working on your motion though, and go see somebody, you know, because we don't want to lose your motion. So now let's say you've been running into it, you've been having your troubles, we're still continuing with these troubles. You probably want to see your doctor, you know, and so you can see your regular doctor, you can see orthopedics. Orthopedics, once again, we're just specialists in the body, muscles, bones, and that. There's actually med ortho, who are family practitioners who did an extra year of sports medicine who just do that as well. But we like to figure out what's going on, and the physical exam part is very quick. You know, normally when patients come to see me, if they're talking, they'll tell me exactly what's wrong. And the big thing that drives almost everyone to come see me is the lack of sleep at night. It hurts so much, they don't sleep. And if I wanted to torture anyone, I wouldn't let them sleep for 7 days, and guess what? We'd die. You know, and that's the truth. So that's why, you know, we get owly. And usually their significant other will bring them in too and say, hey, they're driving me nuts, you know, because they're moaning and groaning in their sleep. So, but we do, and you look at this here, you see this guy here, and they bring that arm up and they twist it. We talk about a Hawkins sign and a near sign. What are we doing? I'm banging someone up against the bone spurs. And it'll be positive. If it's sore, if that bursitis is flared up, it'll be very positive. They'll have pain. And you learn, when you first start out and you're a medical student, always beware of the medical students. You need to go through medical school to become an attending. But medical students, they read that book and they push hard. Oh, you know, so now I've learned. you just have to go real slow. And what'll happen if the patient's chewing gum? They stop chewing gum. They'll start holding their breath. You know you're getting to a spot that's getting sore. It's a positive test. You stop right there, you know. But I don't know how many times as a student, you'd come in and the patient would look, and they'd look at the attendant and say, do we have to have him test our shoulder again, you know? And they're like, why, you know? They're like, what did I do wrong? So, and some of the tests, again, you know, these are all things that have been, they're tried and true, you know, all in what we're looking for. We're looking for tears in the rotator cuff musculature. And each one has a specific way to look for it. We're looking for the bone spur impingements. You're looking for labral tears. Labral tears are probably the hardest thing to diagnose on a physical exam, just because it's so deep and buried. So just a few of the little diagnoses, and it's kind of neat because like Job tests, I got to meet Dr. Job. He's from out in California, you know, and see this guy who has a test named after him was pretty neat. So after our history and physical, that's, you know, like I say, that the history is probably it is the most important part. Physical backs up what our patients are saying. Then we talk about what studies are we going to do. And so basic studies, you know, x-rays. It's very simple. It gives me, unless there's some reason we can't take an x-ray, it gives me a lot of information. And if someone has a really bad arthritic shoulder and it's riding way up because there's no rotator cuff, I don't need an MRI. I don't need anything else. Because if the patient told me, well, it's been hurting like this for the past 5 years, there is no rotator cuff left. It's all gone. You know, and so why sit and do all these very expensive tests, you know, because an x-ray really picks it out. And every clinic, like I say, there's 3 x-rays. If they shoot those 3 x-rays, it gives me tons of information, and we can go from there. So here's interesting, like I said, you know, if someone comes to me and they've had pain forever. You see this top picture there? There's AC arthritis. See how narrow it is? You see a little spur under it, but you see there's a gap there, right? That's where the rotator cuff comes underneath. I can't see the rotator cuff, but I know it's there. What's wrong with this picture? There's no gap. Look at how this is rounded. It matches that humeral head. This here is severe. There's been no rotator cuff for years. It's actually ground the bone down. And there's the crackles. So that's always, this is what you don't want to see. That's someone who waited a long time, waited too long. So axillary view, just some different views again. And so you say, why do they make me go in the spot that hurts? Well, we're looking for certain anatomy. We're looking for points on that. And we do it. So like the acromial spur, this is how we get it. I want to see this on an x-ray so I can see what the angle is of that bone spur. Same thing, there's those 3 views again. Why? Well, it's because I'm looking for that to tell me, am I going to have a rotator cuff problem? You know, everyone, I think it's interesting. They'll come to my office and I need an MRI. Or, you know, they're coming to see me and they've already had an MRI and they haven't had x-rays. And that is very frustrating because those x-rays should have been done first. You know, why are we doing a multi-$1,000 test when we could have done, and granted x-rays are expensive too, but an x-ray give me that. Now, some patients, if we do an arthrogram, it's where we put in dye into the shoulder. So that's the little like needle, and then they push the dye in. And the dye outlines everything for me. So if I see stuff coming up, it shows me a hole. This is the biceps. See how it shadows it? So when we put the dye into the ball and socket area, it follows it, it traces it. It's like being, for me, I think it was a kid who traces so well the outline and then shades in. And that's how it works. Now, some people can't have MRIs. This patient couldn't. That little thing in the corner there, that's a pacemaker. You really don't want to throw someone into a super magnet with steel. pacemakers usually do okay in it, but you need to be in an institute that has someone who can put a new pacemaker back in, because I tried to hold a paper clip when they turned on the magnet in MRI, and it's about 3 to 6 times the pull of gravity. I couldn't hang on to that paper clip. It was jumping that much. You know, and that's why they make sure there's no metal on you on that. But that's an arthrogram, and that one's interesting because there's a hole in the rotator cuff because the dye's out and following it down. Here's one too. You see the dye goes into here. It follows up. It gives me the blush. That blush is that's the beginning partial tear of a rotator cuff. Supraspinatus. Yeah, I even just call them cuffs. Here's a massive tear. It leaks all the way out, and you got the dye all over the place. Pretty easy to figure out what's going on. So then we talk about MRIs. Now, you can make this MRI a whole lot better, and if your doctor orders, if you ever go somewhere and they just order an MRI, you should write this down, question them, say, why am I not having an MR arthrogram? Because if you're going to have an MRI, the gold standard, actually the gold standard is to do arthroscopy to figure out what's wrong, but we're not going to run people into surgery just to figure that out, is an MR arthrogram. Now, there are places that do not do arthrograms, but they'll do that MRI right away. You're like, well, why would I be running that? And as a surgeon, MR arthrogram gives me tons of information. The MRI, and it's hard because sometimes we can't tolerate being in the closed MRIs. When we go to the open scan MRIs, open scan MRI is not a very good study because you lose, because of that open area, you lose part of your definition. But if you're ever going through an MRI for a shoulder, and actually a hip, and sometimes a wrist, it should always be an arthrogram. You know, and if someone says, well, you don't need that, call me and I'll say why you need it. Because I hate to see someone, you know, insurance get billed $2,000 when it should have been done right, when it wouldn't have taken much more effort. So here's an MR arthrogram. The dye is in there. I can see it is now showing me the edges. It shows me a massive tear. It shows me, you know, I see the bone spurs, but I can see where all the dye. It outlines my structures. It shows me stuff. It gives you as a patient your best options. So it's not about me, it's about you guys. But I have to take care of you guys, so I want the best studies, you know, and I will send people to different places to make sure we get the right study because I don't want to do what's wrong on that. So here's a massive rotator cuff. It's retracted way back. MRIs will also show us atrophy in the muscle. If you have severe atrophy, you can't fix the rotator cuff because even if I could pull it back up, it won't work. So atrophy means it changed to fat. So if you tear a muscle off, you tear at the tendon and it pulls back, there's nothing pulling on it anymore, and the body says, why do I waste energy trying to keep something there that isn't being used? It goes away. So we're already back to life is motion, motion's life. You know, you got to have these attachments and keep them working. So that one there you can see on the MRI on my right side, on your guys' left, where it's worn down on the acromion because the humeral head's been bumping up against it the whole time. So large bone spur, I also can see stuff like that too. It outlines them. So we get to the treatment part. So the goal is really, once again, you don't want to see your doctor if you don't have to. So even if you do have to see your doctor, we want to start conservatively. And then I'll see, now there's going to be a caveat to it where I'm like, no, there's times we got to move fast so we can give you the best option. But most of us can be treated conservatively, you know. And so conservatively, physical therapy. Most importantly, it's a well-defined homework. You know, it's your home therapy. It's using the why. It's using what you have at home. You know, that's what really keeps these things going. And most patients, or most people in here, if they've ever been to anything for knees, hips, whatever, building that strength back is the key, you know, and getting it going again. And it takes time. We may, if you can tolerate anti-inflammatories, you know, aspirin, Motrin, ibuprofen, Aleve. If you can and you don't have kidney problems or ulcers, because there's always a side effect. We modify your activities a little bit. So if you want to keep your shoulders out of trouble, one, it'd be nice to be about 6'8" because you could reach into every cupboard with straight ahead of you. You know, because interesting, the shorter we are, the sooner I see someone for shoulder problems because they reach more in their day's time. But if you want to protect your shoulders, you think, okay, if I have to get to something over here, I keep my elbow to my side and it turns this far. Now everyone will have a different amount of external rotation. Turn your body. You think you should always look and face what you're going to grab. If I can keep things in front of me, you'll do fine. If I have to reach up above shoulder height, keep it in front of you. You know, I see someone on a ladder and they're reaching way out, and I'm like, well, all kinds of badness comes out of that. But same thing, I have had young people who, the baby's in the back seat, they drop the bottle, they're driving their car, they reach back to get something, their shoulder pops out. Now you have them trying to drive their car, their shoulder's out, baby's screaming, and these are bad things, you know, so keep it in front of you. At times we do steroid injections, but you know, the same thing, that's an invasive procedure as we go, you know, but cortisone injections, they really can help. I had quite a few to buy me time until I could find time to get my surgery done. You know, there is never a good time for shoulder surgery. Interesting, shoulder surgery is harder to recover from than a total knee or a total hip. And it's, if someone gets a new knee or a new hip put in today, what do we make them do? If you had your new, let's say you had a new knee today, I'm like, get out of bed and get walking on it. You have a rotator cuff repair for 8 weeks, we slow you down. Muscles are getting weak, but we need it to stick because it's really hard to get a tendon to stick to bone again. Versus a replacement, we can get them moving. We get going real quick. So that's why, and it's a year before people kind of like me again. 6 months, they're like, I'm not so bad. At a year, they're like, I'm glad I did it. But let me tell you, the first 3 months, I'm not very well liked, and it's justifiably so. So if conservative measures fail, we talk about surgery. And now, if a tear of a rotator cuff is noted, you know, and this is where I say this, so we always try conservative, conservative, conservative. If a tear is noted and you, earlier surgical treatment, not that I'm pushing for surgery, even though I'm a surgeon and I love to do surgery, we want to get to it because you have a better chance of healing it up because it wants to heal. It's bloody, it's angry, it wants to heal. If we wait really long, it just, what do I say, it just disappears on you. It's unreal how it just rounds off because the body says, okay, well, we're not doing this, let's get rid of it, you know, and it scars in too. So, and we do a lot of this arthroscopically. It's kind of fun, fun for me. We put in these anchors, and I should have brought these anchors. When I say anchors, best way to think of this is sheetrocking. If we're going to hang a picture, I make a hole and I push in one of those metal things and it springs out behind. That is really what we do. So in essence, I twist in an anchor, make a little pilot hole, twist in an anchor, and it has sutures attached to it. So I have an anchor point in the bone, and then I have this really great device that costs way too much, but it loads, it's like a sewing machine for in the shoulder. It loads a suture, I reach through, I grab a hold of the tissue, I pull the trigger, the needle comes up, it hands the suture to me through my top part, which has a little trap door. It pops open, the needle goes up, the needle drops, it grabs my suture up, and I just pass my suture to myself. And so then to help us out, we make them different colors. So you have greens and whites because you're always trying to figure out spaghetti when you're in there trying to put it back together. But you close up the hole, so I'm stitching it back. When you leave surgery, you're not fixed. I just put it back where it belongs. We need the next 8 weeks to get this to stick. And everyone's like, but I had it done arthroscopically, this should be faster. If I opened it up, big incisions, it heals exactly the same way arthroscopically as it does open. Big procedure, big opening, small little holes. You heal the same way underneath. We haven't sped that up at all. The problem we have as surgeons is there's less pain arthroscopically, so you guys don't listen as well. You make a big scar and you hurt them a lot more, they listen better because it hurts. You know, so it has been our challenge, you know, but on the flip side, we don't, when you make bigger incisions, stuff like that, you have to cut through other muscles. Those muscles now need to heal, and so you add that challenge to it, but it takes the same amount of time to heal. So once again, waiting too long, bad. It's better to have an answer and figure out what we're going to do ahead of time. And so here's someone that waited too long, bad arthritis, they're going to end up with a replacement. And that's where we run into it. We're coming up on almost 10 years ago, we did not have an option for these patients. We had no options for them. And so, and I'm going to show you pictures of what was designed, and it's called the reverse total shoulder. So we reverse the ball and socket.
I have that done.
Yeah, and it's amazing. You know, I've been watching. I have friends who do them Actually, I have one of my friends who's probably the #1 guy in the country that does them here in Minnesota now, you know, Jeff Clausen. Yep, he is the guy who does the most, you know, and all that. But it's interesting in how it works, because if you don't have anything, so this is why we're back to the deltoid. If you have no deltoid, you don't even have that option, because the reverse prosthesis is built on the fact that it uses your deltoid to do the work, because there is no rotator cuff left. And so you have to, and I'll show you, you just reverse the sides to it. So, but when they first came out with these reverse total shoulders, they had a 40% infection rate. And the reason is, those were people who kept having injections year after year after year after year. And the organism that was causing the infections, they weren't able to find it. It took a long time to figure out what it was. It's related to acne, and it's Propionibacterium acne. It takes a long time to grow in the lab. And what happens is the labs, after 5 days, will get rid of a culture. Well, you need 15 days to grow these up. Well, so those were the patients, you know, so 40% infection, it was awful. You know, and now it's completely different, you know, and that's why you always have to think about what are we putting into our patients, you know, what are we doing to them, and what can be the side effects. You know, everything I do has a side effect, you know. But here's like just half of, this is a hemiarthroplasty, which means only half of it's replaced. It's the socket isn't, the ball part is, and it's cemented into it. It's a stem and a new head on it. So here's like a hemiarthroplasty. And that's a reverse. And so this is now your liner, and then that ball socket gets put into the scapula, and that's what holds it into its position. It's really a neat procedure. So many ways to look at shoulders. You know, I hope that's what you guys gather from this. But it's always about anatomy. Everything's about anatomy. If you understand your anatomy, if you guys look it up, you'll be as smart as I am. I shouldn't say I'm smart. You'll understand it as well as I do. Because it's mechanical. We have to keep things moving no matter what it is. Even if it's, I can only walk a block today, a block is better than nothing. Because my patients have taught that to me. I have seen x-rays of horrendous hips, horrendous knees, all these arthritis, and I look at it and I'm like, how do you get around? They're like, I do. I walk in and said, Doc, you got to do a little bit every day. The hardest patients to take care of are the younger patients, because they think everything should be fixed right away. The older patients are a little bit easier, but then there's also different demands on stuff too, you know, and older patients listen better, you know, they definitely listen better, usually, on that. But when things don't seem right, you know, there are bodies, we lived with them, imagine this, all of our lives. You know when something's off. You know, get it checked out, you know, because I hate putting my head down in the office when something's been going on for a year. And I'm like, we just lost a whole lot of options. You know, and that's why we gotta keep, you know, you don't want to get a frozen shoulder, you know, and I lecture everyone on this, and I didn't follow the rules, and within 3 days, I couldn't touch the side of my head. It got stiff that quick. And it can happen fast. Patients who suffer with diabetes can get a frozen shoulder real quick. So you gotta work hard at keeping that motion. Being at wall walking, climbing up that wall, doing the cane exercises. There's all kinds of these little things that the therapist can help with that we can teach you real quick. Handouts talk about stuff. Always working through it, keeping it moving, keeping it moving. But the take-home messages are keep that elbow into your side, and if you do have to go up, reach in front of you. Your nose should face what you're going for, you know, and please don't be going up on step stools. Get rid of your throw rugs, you know, because we see lots of broken hips, broken wrist, all these things related. And I understand. I had the best neighbor in Detroit. She was 95, I think, and she used to lecture me about not cleaning off my sidewalk after I mowed. And I'd lecture her because I'd catch her up on a ladder doing her windows. And I always told her I'd do it for her. I'd come over and she's, oh, you're too busy. I said, you don't think of how much more of a problem is if I have to go visit you in the hospital. So on that. To get a hold of us, we have a direct orthopedic line. So you do not call the clinic. You call that number there. That comes right back to our schedulers. That's Ann will answer that. And that's why we love the number 999-KNEE. And it's easy on the phone because it goes 5633. It's an easy number. And I feel sorry because we had that number saved, and then for some reason they gave it to someone else, and we had advertised that number. That lady gave us the number right back. And on the bottom is why we all live up here. My son took that picture out on the lake. That's on Pokekava there. Well, thank you guys very much for coming.